listeners. Welcome back to another episode of Hybrid Healing Hour. Today, we're going to be discussing breast cancer. This is a very big topic of discussion, and we have a very knowledgeable guest on our show today, Dr. Jessica Burgers. Welcome, and thank you for joining us to talk about this not only big but sensitive topic, right? I'd love for you to introduce yourself to our audience. Tell them a little bit about yourself and how you got to where you are today.
Thank you. It's a pleasure to be here today talking about this topic. So yes, my name is Jessica Burgers, and I am a fellowship-trained breast surgeon practicing at Holy Cross Health. I'm originally from Columbus, Ohio, and that's where I started my early medical training. I graduated with my medical degree from The Ohio State University, and then did my general surgery residency at a busy hospital called Riverside Methodist Hospital there. I think my initial inclination, inspiration to go into breast surgery was that my mother was diagnosed with breast cancer when I was in medical school. And so watching her experience with the surgeon and seeing both sides of it from the surgeon's perspective and also the patient's perspective really drove home how important that relationship is, how special that relationship is, and the hope that I could provide that same kind of care and attention to my own patients. From Columbus, I ended up going to the University of Southern California to do a fellowship in specifically breast surgery. And there, I went to that program because they have a strong focus on what we call oncoplastic surgery. And I'm hoping during our discussion we can dive into that a little bit more.
Definitely.
But it just gave me the education on the multiple facets of breast cancer care. And so then I came to South Florida and joined the group at Holy Cross Health as part of the Vienna's Cancer Center. And joining Holy Cross was a decision to be part of a comprehensive cancer team because I know that the outcomes for breast cancer treatment is much improved, not only me as the surgeon, but working closely with the medical oncologist, radiation oncologist, as well as all the other facets of cancer treatment. The other thing I like about my practice is that it does give me a bit of freedom to see patients that also have benign breast conditions in addition to cancerous conditions, the opportunity to do same-day biopsies, because some of the hardest part of all this is the anxiety with waiting for answers, for understanding. And so I've been really happy to be a part of that practice and grow that grow that skill.
So talking about that, actually, so when a patient, because we can go right into like, how do you screen for breast cancer, right? So, I mean, obviously, people know about mammograms, right? So when you say you have same day, if they do a mammogram, like their routine screening mammogram, then they say they need a follow-up ultrasound. They see something of abnormal. They do an ultrasound. You can do, if it's suggestive from the radiologist to do a biopsy, they'll call you and go ahead and do that?
Correct, yes.
Wow.
And so screening mammogram is our tried and true test for detecting breast cancers. And this has been shown in multiple studies to reduce mortality related to breast cancer. But, you know, certain things can be seen best on mammogram, but we also have supplemental imaging like ultrasound. And ultrasound is a modality that's very comfortable for biopsy. And so if a lesion is found on mammogram, then yeah, I can see a patient in the office. I have ultrasound in the office where we can, you know, try to interrogate the lesion and take a biopsy of it right then and there. And then try to get the turnaround time back on the pathology within the next couple of days.
Are most of the patients that you see in your office diagnosed on a screening mammogram, or are they found by feeling a lump?
I would say, interestingly, there's probably an age distribution for that, where probably older patients are being detected on screening mammography versus younger patients present more with a palpable abnormality. Part of that is because some patients haven't started screening because of their age. Right. Also, potentially the more aggressive nature that some of these younger breast cancers can have. But I would say for the most part, screening mammogram really is the bulk of our referrals. Okay.
So the controversy I see in our practice, we tend to have a lot of patients who are following more like functional guidelines now, like more holistic, right? Or they're scared of radiation, or they are listening to people on TikTok or Twitter or whoever else out there who is an influencer stating that mammograms are no longer like they're more radiation. You shouldn't do them yearly. And there's a lot of like, I feel bad publicity on mammograms, and they're thinking that they should just do what thermogram, right? Or thermography, yeah, right? And that can detect heat. They want an MRI instead, or just an ultrasound. And listen, I'm fine with some of those other modalities, but can you please kind of address that?
So again, mammogram is our tried and true test, and everything else we think as being supplemental to the mammogram, and that is because we have lots of data, many years of showing the benefits of mammography. The amount of radiation from a mammography is very low. I think they quote that it's about 2 months of just the normal background radiation that we get just from walking around outside day to day.
From our cell phones, from microwaves, from
The sun.
the
From
sun.
the sun.
Like, I mean, really everything. People don't realize,
if you're up in an airplane, I think,
Exactly.
I've also seen that statistic that it's like taking a flight from New York to LA,
Yes,
that it's a
exactly.
very low dose, and that, even the cumulative amount of radiation over a lifetime is not leading to more breast cancers, and that detection is so important.
And I think that's where people, sorry to cut you off, but breast cancer tends to be age progressive. And we've known this even before mammogram technology was getting even better and better, right? I mean, I think people think, oh, well, is it age progressive because of all the cumulative mammograms you've done each year? But I don't think that's the case.
No, the age factor is partly just related to aging of our cells. And we know that over time, our cells start to accumulate more errors. Our ability of the cells to fix those errors is related to age, that those mechanisms are just not working efficiently, and not so much the cumulative effect of the low dose of radiation. That being said, I will get a lot of questions from patients about just doing an ultrasound or just doing an MRI, which those tests don't have radiation. However, certain types of cancer, certain things can be better seen on some imaging modalities versus others. And so mammograms are really good at picking up calcifications, and calcifications can be some of the earliest signs of breast cancer, particularly like ductal carcinoma in situ, what we might call stage 0 cancer, or some doctors may even call it precancer, which has an excellent prognosis. Once things reach a size threshold or an imaging threshold where it's going to be seen on an ultrasound, now we're, probably dealing with something that is more, a stage 1 or a little bit higher stage. MRIs are a great study as well, but they use contrast. They're a longer study. The positioning can be hard for a lot of patients. And so these are all things that we have to weigh in how we counsel the patient and decide what imaging modality is best. And oftentimes, even when we do an ultrasound or mammogram, the radiologist would like to compare it back to the mammogram again because of how good those are at detecting things.
What do you recommend for women with dense breasts? Do you recommend doing an ultrasound along with the mammogram?
Yes, I think that the ultrasound is a good supplement in the instance of dense breast. I think dense breast is a important topic. I think it's come up a lot in the news now that the federal government is requiring density requirements. A lot of states have had their own individual requirements on breast density. And the idea with the breast density is that on the mammogram, we're looking at the proportion of the glandular tissue to the fatty supportive tissue. And the glandular tissue looks more white on a mammogram. And the trouble is that cancers also look more white. So I think I've heard the metaphor that you're like looking for a snowball in a snowstorm. 3D mammogram helps a lot with that, because 3D mammogram takes the small slices across the breast, and that helps the radiologist look kind of through that snowstorm a little more clearly. And the 3D mammogram is great because it also increases detection, but it also lowers what we call false positives, or those callbacks, where maybe the radiologist thinks they see something, then a woman has to go back and get more testing, lots of anxiety. But with the 3D mammogram, it helps provide just a lot of clarity there. Okay. So 3D mammogram, and then I think ultrasound is a good adjunct there too.
Some imaging facilities, I think, automatically do a 3D mammogram as their screening, but not all. Is that correct?
Yes. I think for a while there was maybe a little bit of lag in insurance coverage. Now, it's pretty
Across
much
the board.
covered universally. And like any technology, it takes time for the newest thing to kind of supplant the
Exactly.
oldest thing. But as the older machines are sort of breaking down and more centers are transitioning to 3D.
Right. Wonderful. So can you tell us, like, what are the top, 3 or 5 cancers that you see in your practice on a regular, basis, I guess?
So the most common type of breast cancer is invasive ductal carcinoma, or breast cancer originating from the milk ducts or the milk drainage system in the breast. The second most common is invasive lobular carcinoma, which is cancer that's originating from the milk-producing cells. There are sort of other subtypes or refinement within those kind of 2 major categories. The thing that really defines our subtypes of breast cancer are actually what we call the biomarkers or the hormone receptors, or morphometrics are another word to describe whether the tumor has estrogen and progesterone sensitivity, or whether it is sensitive or overexpressing something called HER2. And that really is an important definition because it lets us know, A, how aggressive the tumor is, and B, what kind of treatments, particularly from the medical standpoint, will be effective.
So speaking on that, and something as a provider, the way I've tried to, think of those easy, and it is easy way for me to think of it as if it's estrogen receptor, or ER, right, and then PR, progesterone receptor, positive, I guess that's a little more hopeful because you can take a pill to suppress that and prevent it from hopefully coming back, right, for a number of years. But then the HER2, that one you want to be positive or negative? Negative, right. Okay. But then when there's something called a triple negative, that's not so good. Is that like kind of one of the worst ones, would you say?
Yes.
Unfortunate ones?
Yeah. And so hormone sensitive or estrogen and progesterone positive tumors tend to have a much better prognosis, and a lot of times do not require traditional chemotherapies because we have good medications like tamoxifen or aromatase inhibitors that are pill medications that are very effective in starving those cells. And we know women with those type of cancers will do very well. These are very curable, treatable type of breast cancers. When HER2 is overexpressed, it's something that makes the cells more rapidly dividing and a bit more aggressive. But fortunately, with all of our advances in breast cancer treatment, we do have specific targets and specific medications that can act on that HER2 positivity when it is there. That being said, the prognosis in HER2 is much better thanks to these medications, but oftentimes they are, traditional chemotherapies, a lot more side effects. The last is triple negative, and sometimes I like to think of triple negative doesn't have any of these cellular signals, and so these cells are just kind of doing whatever they want and being quite aggressive. Chemotherapies are very effective in those scenarios because chemotherapy targets more rapidly dividing cells, but triple negative definitely has the worst prognosis, needs multimodal therapy, and tends to metastasize or spread more quickly than the other subtypes.
And I mean, there's so many different types of breast cancer out there that anytime somebody gets diagnosed, they're like, oh, I have breast cancer. I'm like, do you know what type? Like, I want people to know what kind they have so they're aware and they can educate their other providers about it. So we know how, I guess, to help in that plan, with their future as well in screenings.
They also don't understand why a friend of theirs had breast cancer and was treated this way. Why am I not being treated that way? And it's hard to tell them that breast cancer is not one disease. It's different diseases.
Right.
Correct. And there is so much nuance and variation, but the good thing about being at like a comprehensive cancer center like Holy Cross, we take a team approach. And so we're really trying to be precise and consider all the facets of each person's individual disease and making a treatment plan. As the breast surgeon, a lot of times I am the first person to meet the patient and I'm kind of taking the lead, but usually we try to get the patients in to meet with medical oncology, radiation oncology early on, because I want their input, their thoughts, their understanding of the latest data information so that we can pick the plan that's going to lead to a cure and the best outcome for the individual.
Can you also talk about staging slightly? Like, how is the role of staging in determining like the plan for the patient?
Right. So staging is based on what they call the TNM, tumor node metastasis. Tumor being the size of the tumor, node being whether there are lymph nodes that are positive, particularly the lymph nodes that drain the breast sit under the armpit or axillary area, and then metastasis if any cells are evident beyond the local breast and lymph node basin. The staging then looks at the various sizes and puts all these numbers together to come up with an actual stage number. And within the past 5 years, the staging for breast cancer also takes into account the prognostic factors, such that a small triple negative cancer may be a higher stage than, say, a big estrogen positive breast cancer. And so they've refined that somewhat recently to account for those features as well.
Okay, that's interesting. And then like the one thing I guess I want to kind of dive into the surgical side of things, right? So I've heard some where people say, oh, I have to do chemotherapy first, then I can do the surgery. But then there's some people who can just have like a lumpectomy, right? And then they can do radiation. So I guess go ahead and talk about like from the surgical standpoint, like what's it like when somebody comes and sees you for that consult, and then I guess the different options.
So from the broadest sense of surgical options, breast cancer surgery falls into two main categories: mastectomy, or removing the entirety of the breast, or a lumpectomy, also partial mastectomy, quadrantectomy. There's a lot of names for what is ultimately breast conserving surgery, just removing the area where the tumor is with a clean margin around the tumor. The decision between mastectomy and lumpectomy depends on quite a few features, but when they did the early studies looking at breast cancer operations, when they compared a mastectomy and a lumpectomy that was followed by radiation, we actually see equivalent outcomes for the patient, meaning in terms of survival or how long a patient lives, they're equivalent whether you take the whole breast or you just take part of the breast and follow it with radiation, or what we call local recurrence, the second events of cancer within the same breast or within the lymph node basins. The decision then becomes, can we get the tumor out with a clean margin? Can we get the tumor out all the way and get that clean margin and still have a breast that looks like a breast? And so, part of the initial evaluation is looking at the overall tumor size, looking at the patient's breast size. Certain types of breast cancers we think will require chemotherapy, as I mentioned before, like a HER2 positive cancer or triple negative cancer. And there's been a lot of data that has come out that has shown improved outcomes if we can treat with the chemotherapy first to potentially shrink the tumor down. And then by the time we get to surgery may be able to be less extensive if that is part of the patient's preference. And the reason that is helpful is because then when we go to surgery, we can get a real assessment of what the response was to the treatment. And so if the patient has had what we call a complete response to chemo, we know that those patients prognostically are going to do very well. But if patients still have residual cancer cells, then that opens the opportunity on the back end for additional therapeutic interventions, typically from the medical oncologist. So these are considerations about, if someone needs to start with chemo versus surgery. As I said, the equivalency between mastectomy and lumpectomy with radiation also puts a little bit of power and choice to the patient. And so there are some considerations in terms of patient preference. And so part of my job is helping, understand the patient's preferences, their values, the things that, how they want to feel and look at the end of the day when we get through the operation. And that's part of what I enjoy taking the patient through it, but I know it can be overwhelming when there are choices to be made.
Absolutely. And I'm sure there's other risk, like more than just like the cancer. You have other risk factors too, like the genetics, right? Mm-hmm. So can we touch on that a little bit? So say somebody might have, ductal carcinoma in situ, which is one of the better prognosis of cancers, but then we do genetic testing and we find that they might have BRCA1, BRCA2, or like a CHEK2, that any of those, and I'm sure there's several more out there, but can increase your risk.
For sure. And that is another reason. So one reason we might opt for a mastectomy is that the tumor is very large. But another reason we may opt for a mastectomy is that someone has a genetic predisposition where we know those numbers of local recurrence go up in that particular population, different from just an average risk woman who does not have that genetic predisposition. And so as part of our multidisciplinary workup, we always offer genetic testing to any patient with breast cancer. And I think that there are a big push with a lot of the societies to say that we should be genetic testing all patients, regardless of how strong their family history is. I think that there was a paper that looked at how if you just tested everyone that came in the door and how many people had the traditional risk factors versus those who did not. And even in 7% of the patients that did not have maybe a strong family history, we would find a gene that may influence the ultimate surgical decision.
Wow. Can we actually go ahead and talk about some like traditional risk factors as well versus maybe like if there's any other non-traditional risk factors like you just mentioned, like the genetics? So traditional risk factors might be smoking, exactly.
Breast implants, do they affect risk?
Breast implants don't affect risk for traditional types of breast cancer. There are some rare forms of like lymphoma and things that can be associated, very, very rare, very uncommon, but not the traditional ductal lobular subtypes that we're talking about here now. Definitely, smoking, obesity. Now a lot of press has been made about alcohol and its risk for breast cancer. Now we're trying to bring more attention to that association.
What about women who played contact sports when they were younger? I read something once that said that may be a risk factor.
Interesting. I have not heard anything to that effect. I would think sports, exercise, all of those things would be good.
But the trauma maybe, because what I've seen is I had a patient who had a car accident, the seatbelt, right, went across her breast, and when she was due for her routine screening mammogram shortly after, and they were alarmed. They saw complete like inflammation, and they were like unable to determine, and so we had to do like a lot. We did some they were really worried about it. Actually, it must have been like seen alarming, and so we did routine follow-ups after, and it went away. But she's like, it had to have been the seatbelt trauma, and I thought that was an eye-opening experience for me as well. So I learned from that. But and I saw like with COVID vaccine, right? They mentioned that they saw a lot of density or inflammation in breasts if you were doing routine screenings within like 30 days or 2 months. I forgot what it was, but I remember in 2020, like the imaging center sent out a notice, like do not perform routine screening mammograms within this time frame after getting a COVID vaccine.
Yeah. So breast trauma, breast being fatty tissue, sometimes injury to the breast can result in bruising or what we call fat necrosis, where some of the fatty tissue may die and feel like a lump or look like a ball on imaging. And so it takes an astute radiologist to kind of assess what is a mass that is cancerous versus a mass that is benign. And sometimes we aren't always sure on the imaging, and we'll want to do short-term follow-up and put it into context of the clinical history. Again, this is another reason why I like having the freedom of the ultrasound in my office,
Right.
because, as a breast surgeon, I'm good with the breast exam, but the ultrasound is just, like my stethoscope. It really helps me to better investigate things. And if there's any question, a biopsy gives us tissue and may give us insight. The thing with the lymph nodes related to the COVID vaccine is that we were getting a lot of lymph node swelling after the vaccine, which would be expected because the lymph nodes are generating an immune response, but they were showing up on mammography and perplexing the mammographers at first. We've seen it happen with other vaccines, like the flu vaccine, but the COVID vaccine really just generated a very robust response. And so that was why they were cautioning patients, because they were getting a lot of these callbacks and this extra anxiety and imaging and biopsies and things that were all just temporary swelling that then went away once, the antibodies had been made. And so that was something we learned from that COVID vaccine experience.
Right. And then, so what about how do we reduce our risk? Obviously, don't smoke, limit your alcohol use, and try to exercise, eat clean. I'm sure lifestyle makes a big difference, but what about like the onset of menarche, like starting the menstrual cycle or breastfeeding? Do those have a factor of like reducing or increasing risk?
So we would think that a woman's hormonal history can influence their risk. And so women with younger age of menarche, later age of menopause have a slightly increased risk. Early age of childbearing and breastfeeding does decrease risk. So those kinds of things we have some control over, but not exactly. But they do influence some of the risk models that we use in trying to estimate what someone's lifetime risk is. So that model is called the Tyrer-Cuzick model, is one of the kind of most comprehensive. There are some other models like the Gale model that is also exists in trying to estimate what someone's individual risk is for breast cancer. The things that go into like a Tyrer-Cuzick model are the hormonal history, the things that we mentioned, the age that someone had their first child. We also include the breast density. We know women that have greater breast density, more breast density, have a bit of an increased risk for breast cancer. And then the family history. And that goes back to the piece about genetics. The more first-degree relatives increases risk, even outside of having a positive genetic test. And that may be some of our limitations of what genes we can test for today versus what the more we'll understand, or maybe there is, a separate hereditary component. And so these models are a way to try to decide which patients would benefit from increased screening, things like MRI, and meeting with a breast surgeon to be more vigilant about their overall breast health.
Yeah, I noticed some people are alarmed when they see the Tyrer-Cuzick on their mammogram, and is that something, so if it says that somebody's at like a 30% increased risk of breast cancer with that score, but their mammogram is normal and they recommend yearly, is there anything as a provider that we should have a change of plan with that? Or is it something we just can say, okay, make sure you go every year for your mammogram, and if we start to see densities, order the ultrasound actually as well?
So the current recommendation for patients whose Tyrer-Cuzick is over 20%, and I think 20% is used because the average risk is around 12%, so that 1 in 8 women, so 20% is roughly about double that, and so that is a number we use to say that a patient is at high risk or elevated risk for breast cancer. And this then provides potential justification for additional imaging modalities like MRI. MRI can be helpful because it uses contrast to look at the blood flow in the breast to try to find lesions that might be hidden by breast density. And typically we like to stagger the mammography from the MRI by about 6 months, with the idea that each test is happening once a year, but they're kind of leapfrogging each other. And so with this, we're potentially identifying interval cancers instead of allowing a patient to go 365 days between each test.
Would you say that's considered the concept of early detection?
For sure. And I think, we always talk about early detection, talk about screening. Another component of this is what we call the risk assessment, and trying to identify which of these patients are at high risk and probably do need a little extra investigation, potentially referral to like a breast surgical team. We have a high-risk nurse practitioner who helps to keep tabs on the testing when it's due. And so that's just another facet of early detection, is knowing a person's individual risk and trying to tailor their screening recommendations to their lifestyle factors, their hereditary factors.
Yeah, I mean, I had my own mother actually, went for her screening mammogram, and it was very lucky. They found it was like 4 millimeters, and they were able to almost get all of it with the biopsy alone. And luckily, she only needed like a lumpectomy and then radiation, and phenomenal prognosis. I mean, we were very lucky. But, if she would have skipped the mammogram, or if, just delayed it, like I just felt like that because they saw it so early, we were able to have such a great outcome.
Exactly. And that's why, we make such a big deal about
right.
screening and breast awareness and all of these things.
Anytime I have somebody who's like, I don't know, I think I'll go every 2 years, I'm like, let me tell you a story. So yes, let's dive right into this. I'm so curious about the oncoplastic or
Yes, oncoplastic.
Okay, tell us more. Like, tell us what you learned, what you do, and.
So we started to dabble into a little bit of the broad categories of mastectomy and lumpectomy, but really there are sort of categories or ways to approach these types of surgeries. And so oncoplastics is combining the word for cancer with plastic surgery. And the mentors that I worked with out in LA, at the time, they could see that the plastic surgeons would do techniques like breast reductions, breast lifts, and as part of that operation, they would be removing and quote, throwing out a piece of tissue. With a lumpectomy, we purposely want to remove a specific piece of tissue in the breast. And so we can use the tissue that we are removing in the consideration of a breast reduction pattern, sort of reshape the breast in a way that at the end where we've accomplished a lumpectomy, but we've actually made the breast potentially look aesthetically better. And so typically this is a variation of a lumpectomy where after surgery we would still recommend radiation, but oftentimes we can also operate on the opposite breast, the contralateral breast as well, to improve the overall symmetry so that there isn't a defect or deformity created by doing the lumpectomy itself.
Wow, that's really impressive. Okay. I like that because you're right. A lot of women will have like a dimple where they had the lump removed, or like the scar. To me, a scar is no big deal. Like you're alive, right? But like the dimple can make some people feel a little off shape, like you said, depending on how big they had to have that removed. And it's also hard to find bras that one boob might be bigger than the other. That's just, you have to go get custom fitted. And luckily, as medical providers, oftentimes with my patients, we can write prescription bras, and they can get so many a year covered by the insurance, which is something that is, I'm glad, insurance will step up and pay for that too. So that sounds like, has that been going on for a while, or is that something that you can get covered by insurance as well?
It is, and that's partly because there is the Women's Health and Cancer Rights Act of, I want to say, from 1998. So it's not something that is new, but written into that law is that women with breast cancer are entitled to breast symmetry. And so if we anticipate that there will be some asymmetry, that can be covered through insurance. And so in terms of approaching breast conservation, sometimes small tumors, we can take those out with minimal change to the breast size and shape. But as we're starting to remove bigger tumors, or sometimes in patients who maybe have had long-standing issues with macromastia, having really large breasts, back pain, now we may have an opportunity to address multiple medical issues, the breast cancer, in addition to the breast size creating those additional health issues and discomforts.
Okay. And can you talk about like lymph node surgery as well, like the lymph node retrieval, or removal, and a little bit about side effects or risks associated with that?
So lymph node surgery, typically when we perform lymph node surgery now, we do what we call a sentinel lymph node sampling or sentinel lymph node biopsy. In the traditional iterations of breast surgery, they used to do what was called an axillary dissection, where all of the packet of lymph nodes that sit under the armpit area would be removed. And the trouble with doing that is that some of the lymph nodes that drain the breast also start to drain the arm. And I think, like lanes of traffic, if you start to decrease the number of lanes, the traffic gets congested. If you decrease the number of lymphatics, then the arm can get really swollen, or what we call lymphedema. Now we do sentinel lymph node biopsies because that is a way to try to identify the first few lymph nodes that are draining the breast, and try to avoid those lymph nodes that are draining the arm. And so we can actually inject dye into the breast and see how it maps to the lymph nodes and select the first few to send to the lab to assess. And if we do not see that there is an extensive burden of cancer, we do not have to automatically do the axillary lymph node dissection. There are even some newer studies showing that if we have really good imaging modalities now, that if the imaging is negative and there are no clinical concerns for lymph node involvement, sometimes we're even omitting sentinel lymph node sampling altogether. And this is because the complication or the side effect of lymphedema is really hard for patients. It can be really challenging to manage. Fortunately, microsurgery trained plastic surgeons, there are some new techniques and things to try to help improve that overall, but we always want to try to minimize the risk in our patients and only take out as many lymph nodes as absolutely necessary.
Yeah, because I know like some people can't have their blood pressure taken on that arm because the compression could trigger some lymphedema.
We definitely don't see it as much now as we used to.
Right.
I mean, once upon a time, we were seeing quite a few patients with lymphedema of the arm.
Right. And one thing I want to touch on before we wrap it up is going back to that whole overall care approach that you have, the collaborating approach you have with the oncologist and as the surgeon. And can you talk on how important that is? And you already mentioned Holy Cross does it. I love that approach. Can you explain a little more on how, from the time the patient is diagnosed with breast cancer to the time of the surgery or post care as well?
So typically when a patient is diagnosed, whether I diagnose the patient by performing the biopsy myself or they get referred to me having the biopsy done at an imaging center, typically as the surgeon, I'm the first person to see the patient and start to develop their care plan. At Holy Cross, we actually have something called our multidisciplinary clinic, which is pretty special, where on Wednesday mornings, we actually have all of the doctors on the team come to meet with the patients one-on-one. And so in that visit, the patient has the chance to meet with a medical oncologist, meet with a radiation oncologist. We also have a cancer dietitian, someone who helps with the genetic counseling, and a social worker. And so in that particular visit, a patient is like a one-stop shop where they get to spend time with each of these specialists and hear cancer from each of their perspectives. And after the patient meets with these providers one-on-one, then we all sit down and have a conference where we review the imaging, the pathology, and make our recommendations. I think a lot of patients find that very helpful. Instead of having to make multiple different visits, everybody is basically coming to them. If a patient feels like that's overwhelming, then, I'm able to reach out to my other colleagues and set up one-on-one visits in that scenario. But it's typically after that multidisciplinary conference, what we also sometimes call tumor board, where we make recommendations. And then if chemotherapy is going to be the first step, then the medical oncology team kind of takes point. But if it is something where surgery is going to be the first step, then I communicate that with the patient and see them back for another kind of preoperative visit. After surgery, it typically takes about a week to get the pathology result back, the final pathology, and then from there we can guide them about, what treatments after surgery will be required.
And on that note, how do you approach the emotional and psychological aspects of breast cancer surgery, I guess, with your patients? I mean, obviously I always hear the term, they're not hearing everything that you're saying because they're still probably overwhelmed, what's your intake or partake on that?
Yeah, no, it can be so overwhelming, and there's definitely a lot of information that is provided to the patient at some of these initial visits. I'm hoping that when the patient comes to see me that their referring provider has given them a little bit of overview, a little bit of time for them to digest the information. But we have a lot of different materials, handouts. I participated in something called the SHAIR, SHAIR collaborative, which was providing what they called a shared decision-making aid, or a handout with graphics and pictures and things to provide to the patients that after we've spoken, they have the opportunity to review. I always encourage patients to bring a family member or someone with them, someone that can provide another set of ears, another perspective. And then in our team, we also have what we call a nurse navigator. And so as a surgeon, sometimes I'm in the operating room. I'm not always available to take a phone call, but we do have a nurse who's dedicated to help try to answer some of those questions quickly. And if not, then I am available to call them back when I'm free and go over things with them. But as I mentioned at the beginning, my mom is a breast cancer patient. And so, I always try to keep that in mind when I'm dealing with the emotions that can be high and stressed and scared, and just trying to help walk the patient through it as best we can. And the thing about breast cancer is we have such good treatments and such good prognosis, and just try to keep the positive attitude, the emphasis on how we're being precise and taking care of each patient as an individual.
How long do you typically stay involved in the patient's care?
In my practice, I do what we call survivorship, meaning following the patient even beyond their original treatment. Typically, after we've finished all active treatment, usually I end up seeing patients back every 6 months. For the first few years, we know a lot of recurrences kind of happen within those first couple years. If patients get out to about 3 to 4 years, those visits may space out to once a year. I like keeping tabs on people. I think it's also nice to see people when they're maybe in a better state than maybe when I first met them. But also, as I mentioned before, I have some things in my office, like the ultrasound, and I'm very familiar with looking at mammograms, and so I like being involved and being able to double check everything for the patients.
I love it.
Yeah.
Well, I want to thank you, one, for coming on, and two, for, doing what you do and changing people's lives and being there for them, because, even whether you're having a mastectomy and then you do the reconstructive surgery or which we didn't even touch on.
I feel like we could do a whole nother one of these
exactly.
just on that.
Exactly. So is there any, if you could give one tip to our audience today, what would that be? I know I'm putting you on the spot.
Mm-hmm.
Maybe just do routine screenings. Right,
get your mammogram.
Yeah. Get your mammogram and check your breast yourself. Do routine screenings. Get familiar with your girls. And, if you feel something, if you know what your normal is, you can always catch an abnormal quicker.
We didn't even talk about male breast cancer. That's probably
right.
a
I know.
whole
That's a whole other topic we could talk about.
We have there's so many topics here. One thing we talked about high risk and trying to determine if you're high risk. There are a lot of free calculators and things online too that can be used to find out what your Tyrer-Cuzick risk score or Gale risk score is, and
it's a great idea.
Bring that up to your primary care physician, or you can look up our team, and we'd be happy to help guide you through when to start screening and
on that
where
note,
to do it.
Why don't you tell us how they can find you?
So as I mentioned, I'm part of Holy Cross Health. My office is located in the Biena's Comprehensive Cancer Center on North Federal Highway in Fort Lauderdale. You can also find my website is drjessicaburgers.com, where you can learn a little bit more about me and the conditions that I treat.
Awesome. I'll have all that in the show notes as well. Thank you so much.
Thank you.
Thank you.
The information contained in this podcast is provided for informational and educational purposes only and is not intended for the purposes of diagnosing, curing, treating, or preventing any disease. This podcast is provided on the understanding that it does not constitute medical or other professional advice or services. Before using any products or services referenced on this podcast, consult with your healthcare provider, carefully read all labels, and heed all directions and cautions that accompany the products. Information found or received through the podcast should not be used in place of a consultation or advice from a healthcare provider. If you suspect you have a medical problem or should you have any healthcare questions, please promptly call or see your healthcare provider. This podcast, including Dr. Brian Marias, Deanna Weilbacher, and Hybrid Medical Solution, do not claim responsibility for any adverse effects from the use of information contained herein. Opinions of guests are their own, and this podcast does not endorse or accept responsibility for any statements made by the guests. This podcast does not make any representations or warranties about guest qualifications or credibility. This podcast may contain paid endorsements and advertisements for products or services. Individuals on this podcast may have a direct or indirect financial interest in products or services referenced.
If you would like to submit any questions or if you have any topics you would be interested in hearing about on future episodes, please contact us through our website, www.hybridmedicalsolution.com. That is solution with no S at the end. Follow us on Instagram and Facebook, all under Hybrid Medical Solution.